Hello, everyone. On behalf of the Coalition Against Typhoid and our collaborators at the World Bank Group, I would like to welcome you all to our World Water Week at Home session, driven by data, targeting WASH interventions for enteric disease prevention. In WASH, to those not familiar with the term, is the acronym for water, sanitation, and hygiene. My name is Denise Garrett. I am the director of the coalition, and I will be moderating today's session. Today, we'll be focusing on the relationship between waterborne diseases and WASH, and how new disease surveillance methods can inform efforts to improve access to safe water and sanitation service. We will begin today's sessions with two great presentations from Dr. Steve Luby of Stanford University. Steve, could you please wave hello so everybody knows where you are? And for all the presenters, please also wave hello when I say your name. Our second presenter will be Dr. George Joseph and Sophie Aileen from the World Bank Group. And after the presentation, we'll then move into our panel discussion where myself, Steve and George will be joined by two additional panelists, Dr. Ranjiv Klush of the Acquire Institute and Dr. Aidan Cronin of UNICEF Zimbabwe. So before we jump into the presentations, just two quick housekeeping items. First, if you have any technical difficulties during our session, please utilize the chat box on the right-hand side of your screen to contact a member of our team who will help you to troubleshoot. The same chat box may also be used to submit any questions for our presenters ahead or our panelists ahead of our panel discussion. And with that, I would like to introduce our first presenter, Dr. Steve Luby of Stanford University, who, as both a physician and epidemiologist, has focused on infectious disease transmission in low-income countries, including strategies to improve WASH. Steve will be kicking things off today with his presentation on environmental surveillance for typhoid. Steve, you have the mic.
Typhoid is transmitted from the feces of one person to the mouth of another. Typhoid persists as a public health problem in cities where the environment remains contaminated by feces. So surveillance of this environment can be informative. I'll describe some examples of what has been learned in recent environmental surveillance efforts for typhoid. If you live in a wealthy country, you're accustomed to having drinking water available whenever you turn on the tap. But in many low-income countries, water is available only intermittently. When I lived in Karachi, Pakistan in the 90s, we'd get water 2 or 3 days a week. Maybe for an hour or two. And McKinsey and Ray note that there's no major city in India today that has water available 24/7. Municipal water suppliers collect water from the environment in these cities. They treat it, and then they distribute the water to users across the city. They often test the water quality right here, right as it comes out of the water treatment plant. And in general, because it is a water treatment plant, the water quality usually meets WHO criteria for potability. But then they put the water into a distribution system. And when people finally get the water, it's at the end of the distribution system. And there can be some deterioration along the way. To think about the deterioration that an intermittent water supply might generate, I want us to go down and think about what this pipe looks like underground. So if the pipe is intact, there's no connection between the water in the pipe and the environment. But there might be breaks in the pipe. To get an insight on how frequently we might find breaks, let's look at some data from Europe. In Europe, cities generally know how much water they put into the system, and then they have meters to know how much comes out at the end users. And so what this shows is across a wide range of European countries, 20% of the water that's put into systems is lost. And so what this tells us is that breaks are common. Pipes leak. Now, if water is on continuously, that means that there's pressure in the pipe. Any breaks in the pipe will mean that water will leak into the environment. You might lose some water, but it's not a threat to water quality. But what happens if the water turns off? If water turns off, the pressure dynamic changes, and the water inside the pipe is now at lower pressure, and so the contaminants from the outside can leak in. So it has been studied in numerous countries, and intermittent water supply guarantees that people will be drinking a contaminated water supply. And if, so it means then that that is the experience at the receiver's end of these water distribution systems. So if we start looking about within water systems that people actually drink, what is there evidence of environmental contamination for typhoid? Professor Sabin Baker, with colleagues looking at the Oxford University Clinical Health Research Unit, wanted to try to figure this out. And it's a hard problem because it's difficult to grow typhi from water. So this girl is collecting water from a stone spout in Kathmandu. These are very popular. This is groundwater that percolates through the Himalayas and is thought to be fresh and clean and very popular. Indeed, looking at patients who came to the hospital, Karki and Baker identified the 10 most commonly used water sources among these patients, and they were these stone spouts. They collected water samples every week for a year, and instead of doing culture, did a real-time PCR test for Salmonella typhi and paratyphi. And what they found was that 77% of the samples were contaminated with typhi, and 70% were contaminated with paratyphi. And you look at this week by week, there's no big seasonal variation, high levels of contamination. So this is a setting where there's a lot of typhoid fever, and the water people are drinking is contaminated with these organisms. We wonder, though, if this is something unique about the water ecology in Nepal, would we also see this in an engineered water system? So Saha and colleagues in Dhaka looked at municipal water quality. So they did a study looking at 59 patients with Salmonella typhi or paratyphi, and they collected a 1 liter source drinking water sample. So this is water that's being delivered by the Dhaka Water and Sewage Authority, and they used the same PCR approach as was used in Nepal, and they found 54% of these municipal water samples, 58% had Salmonella typhi, and 24% had Salmonella paratyphi. As part of the Surveillance for Enteric Fever in Asia project, Jason Andrews and colleagues conducted blood culture surveillance in the Kathmandu Valley of Nepal. So this is now a decade later after the study by Karki and Baker. And those magenta dots, those are places where people were diagnosed where they lived who had typhoid fever. The blue dots are the water samples that the team collected to test for typhoid. So again, they used RT-PCR, but this time they found very little typhi. None in 400 water supplies, typhi only 2 with paratyphi. So this was surprising after only a decade have elapsed, But water hydrogeology has changed in Kathmandu since the Karki study in 2009. The water table has fallen steadily by at least 0.7 of a meter a year. And this is because a lot of people are moving in and groundwater is being withdrawn faster than it is recharged. In fact, the stone spouts that Karki and Bakir studied are now dry. But Andrews and his colleagues recognize that people in Kathmandu continue to have contact with water, especially with river water. These women are cleaning vegetables in the river, vegetables that will then be sold throughout the city. So Dr. Andrews and his colleagues implemented water sampling testing. For a year, they were looking throughout the river system in Kathmandu Valley and looking at sites that are either upstream from Kathmandu or downstream. They took 45 milliliter water samples, they put them in media to help it grow, to incubate, and measured these specimens for PCR. And if you look here on these maps, what you can see is upstream, the water is pretty clean. The size of the dot and the colors reflect how many months the specimens were positive. So upstream of Kathmandu, the rivers were pretty clean. But as you get down into the populated areas, you find that more and more of the samples are contaminated, so that by downstream, nearly all of them are. These are the data for the typhi contamination in water, and these are the data for the paratyphi contamination. They're nearly identical. So if we consider rivers in the Kathmandu area, they're frequently contaminated with both Salmonella typhi and paratyphi, and we see progressive contamination that's consistent with untreated sewage discharge into these rivers. And people interact with rivers in Kathmandu, both for bathing and washing produce. So the river water is likely more important than the drinking water, which we had tested and found negative as a pathway of typhoid transmission in Kathmandu Valley. So this is some pretty exciting examples of the way we can use environmental surveillance, but there are also some caveats. The best DNA extraction kit for water is no longer available. And this is just unfortunate. The company that was making it was bought out by another company, and it's no longer available on the market. Colleagues in Bangladesh and in Nepal have been working, trying to do the best with available extraction kits. And there's still more work that needs to be done to optimize them. They'll probably never be as good as the original kit. And all of this work has been delayed by the COVID-19 pandemic. So right now, we don't have an optimal water extraction kit. In addition, the information value of detecting contamination in sewage sometimes can be really helpful. Like, it's really helpful in Kathmandu to understand this fecal-oral transmission pathway when drinking water was so clean. And it's also clearly useful when the agent where surveillance is being conducted for example, polio, is a target of eradication. But by contrast, if we already know that there's an infection that's widely circulating, like SARS-CoV-2, finding it in sewage doesn't really tell us a lot that we don't already know. So in conclusion, new environmental surveillance tools can help clarify the pathway of typhoid through municipal water and sanitation systems, and it can show where improvements can interrupt exposure. And this is important because it can tell us what might we be able to do to interrupt typhoid transmission. And in turn, by having such specific data, we can potentially increase political motivation to improve the water distribution and sanitation systems. If we can go to politicians and say, look, the municipal water system is delivering water that is contaminated with Salmonella typhi, and this organism is causing great harm to the residents of the city, this can actually focus on improving water distribution. So this is a new area of exciting development for the control of typhoid. Thanks.
Thanks, Steve. Next, I'd like to introduce George Joseph and Sophie Aileen from the World Bank Group. Dr. George Joseph is a senior economist in the bank's water global practice, whose research includes impact and evaluation, water and sanitation, and behavior economics. And Sophie Aileen is a water sanitation and planning consultant with the Water Global Practice, with expertise in water, sanitation, planning, and evaluation in Sub-Saharan Africa and Latin America. They will be presenting on the use of geospatial approaches and big data for planning and targeting interventions against infectious diseases. Go ahead, George and Sophie.
Hello and welcome to this World Water Week session on using data-driven approaches to target wash interventions for infectious diseases. My name is George Joseph. I'm a senior economist at the World Bank Water Global Practice. Today, together with my colleague Sophie Aileen, we will be sharing with you an overview of how we have been using geospatial approaches and big data for planning and targeting interventions against cholera and COVID-19 in Zambia and Zimbabwe. In this presentation, we will outline the benefits of taking a data-driven approach and the kinds of policy questions this approach has helped us to answer. Then we will go into the results of some geospatial analysis and agent-based modeling work. As we are all aware, coronavirus pandemic has brought into sharp focus the need for governments around the world to plan and target more efficiently their responses to infectious disease outbreaks. And though COVID-19 will remain center stage in global health for some time, there are other older diseases which continue to contribute to a large portion of the disease burden, such as cholera and typhoid. Finally, a proliferation of new data sources and empirical methods offer an opportunity to gain fresh insights into policy and planning questions. So why a data-driven approach? In the water global practice at the World Bank, we currently have about 318 lending projects and $34.5 billion in commitments. These investments sound like a lot of money, don't they? In reality, when broken down in any given project, the investment may only cover a portion of the total need. This makes it all the more important to target appropriate investments where they will have the most impact. And this is where data and statistical methods come handy. So what are the kinds of questions we need to address? Here are a few of the questions we asked ourselves or that the governments asked us. For cholera, we focused on trying to understand the factors that made the greatest contribution to the disease risk. What were the sources of disease risk? In which part of the city we observed the higher levels of risk? How can investments be made to reduce these risks? For COVID-19, we modeled the trajectory of outbreak under different scenarios and saw how different suppression tactics, such as movement restrictions or hygiene measures, could potentially limit the spread of the virus. Starting with cholera, we took a geospatial approach with high level of spatial resolution. Our methodology involved 4 steps: explore, model, identify, and target. To give a bit of background, in Zambia, the cholera outbreak of 2017-18 resulted in almost 6,000 cases, of which 92% were concentrated in Lusaka city. Meanwhile, Zimbabwe's cholera outbreak in the following year resulted in cumulative total of 9,719 cases in Harare alone. Since John Snow's discovery in 1854, cholera risk is well known to be associated with poor water and sanitary conditions. However, there are multiple pathways for contamination and infection which can interact with each other as shown in the slide. In Lusaka, we collected data on how these different possible avenues of transmission could translate into actual data points. We collected data from numerous household surveys, utility data, and global data sets. What was important was to gain a spatial picture of how the risk was distributed across the city. A similar set of data was collected for Harare as well. All of the data was input into producing a geospatial predictive model. That model could combine various risk factors to create a predictive surface of where cholera cases might be in the city. On the left-hand side, you see the results of that prediction from the model, while on the right-hand side, you can see the cases mapped in pink and overlaid with the prediction. You can see how accurately the predictive surface reflects the distribution of cases that occurred in Lusaka. In Harare, we conducted the same exercise, and you can see the results. Just from looking at these two sets of maps, we can see how different in spatial character, these two outbreaks were from one another, despite being caused by the same disease. With this in mind, the next step is to identify which factors contribute most to explaining the cholera risk. In Lusaka, we note that areas where unimproved pit latrines were clustered was highly spatially correlated with areas where cholera cases occurred. Meanwhile, in Harare, there was a high spatial correlation between case density and the density of sewer burst reported in the southwest of the city. So what can we do with this information? We looked at a series of possible investment scenarios to analyze which combination could result in the greatest reduction in cholera risk. Each of these had different cost implications. Then we looked at which wards of the city could be targeted with certain infrastructure investments to reduce citywide cholera risk the most. As the graph shows, a large proportion of the cholera risk can be reduced by targeting just the first 5 or 10 wards where the problem is most acute. After which point, the impact on case reduction levels off. Such information can be extremely useful in deciding where to invest in the city. Now I will hand over to Sophie, who will talk a bit about our work on COVID-19 in Zimbabwe.
Thank you, George. Hello, everyone. My name is Sophie Ayling, and I'm a water sanitation and planning consultant working for the Water GP of the World Bank. The work I'm presenting to you today builds on the cholera mapping that George has just shared by using dynamic population movement data in conjunction with a method called agent-based modeling to inform the risk of transmission of COVID-19 in Zimbabwe. The first case of SARS-CoV-2 in Zimbabwe was reported on March the 21st, 2020. The government responded quickly with a lockdown imposed just 7 days later. As a result, the initial number of active cases stayed well below 100 for a good 2 months. However, since June, the trajectory has taken off with over 4,000 cases at present. Around the time that the lockdown was announced, our team engaged with the Zimbabwean government's core modeling group. Given our work modeling cholera in Harare, they were interested to know what insights our analysis could bring. The work we conducted used an agent-based model, or ABM. ABM is a computational approach to disease modeling that focuses on modeling individuals' characteristics and behavior within their environment. Here are some of the earliest results of those simulations using early case data and transmission rate estimates from European countries at the time. It shows how, if a harsh lockdown was imposed and all the population complied, the spread could be contained and we would not expect to see a peak this year. That's the beige line at the very bottom of the graph. We also modeled intermediate scenarios using the mobility data we identified, using mobility data, where we identified districts which had the greatest level of inbound and outbound movement. From the brown line in the middle of the graph, you can see that selectively applying a localized lockdown in the 10 highest mobility districts had the potential to greatly reduce the peak of a first wave. As of now, the Zimbabwean government is implementing a partial reopening. However, our modelling efforts are ongoing and continue to be informed by new data and estimates of the rates of transmission in the country at present. Another benefit of ABM is that it enables us to see spatial differences. We can look district by district and see how the virus could potentially spread across the country if it were to start in one location and then move to another and so on. This animation shows what could have happened had the virus not been contained and how it could have spread across Zimbabwe. Finally, relating back to WASH, we conducted a theoretical exercise to model how changes to hand washing facility access might reduce the risk of COVID transmission. WHO and governments have been actively promoting hand hygiene to reduce the spread of SARS-CoV-2 based on knowledge of how other viruses from the same family, such as SARS and MERS, spread. Unfortunately, there are limited studies that seek to quantify what the risk of not having adequate hand washing would look like in the case of coronavirus. Here we sought to identify districts with the lowest access to hand washing facilities with water and soap using geospatial interpolation. We included hand washing risk, as shown on the previous slide, as part of the transmission model. Using estimates from Imperial College London's work, we modelled scenarios in which hand washing improvements could reduce transmission. Ultimately, this could have a knock-on effect on reducing the number of deaths. While this is still a theoretical exercise, it does demonstrate the need for us to understand more about the quantifiable impacts of hand washing on disease transmission to include COVID, cholera, and numerous other infectious diseases. I will hand back to George now for some concluding remarks.
Thank you, Sophie. We hope you have enjoyed the presentation today and look forward to the discussion to come. To sum up, we have found that geospatial analysis can be used to inform where to target investments to best reduce the risk of cholera. This type of analysis is not limited to cholera and is not limited to the 2 countries presented here. Better data can improve our estimates and predictions. This only underscores the need for all stakeholders to continue to collect accurate data and share them across different researchers and other users. The work on COVID that Sophie presented here shows how agent-based modeling and cell phone data can help to inform lockdown policies that seek to mitigate the spread of a virus. In future, it could be used to inform localized responses with less economically damaging consequences. Finally, just to add that none of this work presented here today would have been possible without the collaboration and support of multiple stakeholders in Zimbabwe and Zambia. Thank you again for your time, and we look forward to the discussion.
Well, thank you, George and Sophie. Now we'll be moving on into the panel discussion and Q&A portion of our session. Again, if you have any questions, please submit them via the chat box. I will start by introducing our 2 additional panelists. Dr. Ranjiv Klush of the Acquire Institute is a microbiologist by training with extensive research in water quality management in low resource settings and exploring solutions to waterborne diseases. Dr. Ranjiv, can you wave hello? And we also have the pleasure to have with us Dr. Aidan Cronin of UNICEF Zimbabwe. He is a civil and environmental engineer with expertise in water and sanitation, who has focused his research on wash provision to the most vulnerable populations. So the first question I have today is something I hope all of our panelists will weigh in on. How can we, as infectious diseases researchers, engineers, health economists, better engage government agencies, water authorities, and service providers to improve both water quality and public health.
Denise, I can start if
please.
Appropriate. I would note that for much of the sector, there may be assumptions that water safety management is a challenge that's being well addressed by existing authorities and regulations. As we've just heard, particularly from Steve's presentation, in many areas, that is many geographies, that is not the case. I would argue that water safety actually requires a PR campaign that raises it within the sector. It raises its prominence within the sector to the levels that we've seen for other issues that have received a lot of attention. For example, the reduction of open defecation. This is because the attention focused on open defecation has raised its prominence to very high levels, to the extent where you see now governments such as in India making it a formal mandate to reduce. I think we need I think it's important to consider how we can raise the prominence of water safety management on the political agenda as well.
Thanks, Steve, or anyone else?
Yeah, I would certainly agree with Ranjit that part of this is how we frame it, and part of it is bringing data forward too. If we're working in resource scarce areas, and so we're not always going to be able to do everything that we want to do. So being able to generate the data on where the problems are is important, and then working within constraints to deliver the best we can. So I do think that it's both advocacy and good data can help advance us.
Yeah, thanks a lot. And maybe I can complement what Steve was saying. Sorry, your name appears as my name. I don't know why it's doing that, but
I'm a fan.
But yeah, I wanted to come in on I wanted to come in on your point, you know, about the data and driving evidence-based approaches and really having solid data to push forward our WASH sector. I mean, what we've seen here in Zimbabwe is that generally we collect data along two kind of lines of implementation. Of course, rapid emergency response, and then longer term development work, and that's more and more, unfortunately, our you know, with year-on-year inflation here at present at about 800%. A lot of our work is really around the first one, humanitarian responses. But I want to challenge the notion that humanitarian data doesn't need to be good quality and doesn't need to help longer term development interventions. And George's presentation was a great example of that, whereby some of the initial data that we collected fed into later modeling. So that data was some of that data was collected by our rapid response teams, looking at case area target interventions. And we know that this is important because if we can actually substantially reduce the risk of cholera transmission if we get to those neighboring households within the first few days of cholera symptoms. And we did that in the example that George was mentioning in Zimbabwe, the cholera outbreak from September 2018. And what we found was that actually, you know, Steve's point on resource challenged environments with actually quite modest sums of funding. So I'm talking about, you know, something like $3,000–4,000 a month for rapid response teams, because these were government teams. We were not having to pay salaries, but with that we were able to first tackle cholera and then jump onto typhoid when the cholera cases started to go down, and you know, overall through that approach in the first 5 months post the cholera, we were able to reach over 12,000 households. So what I'm trying to say with this is and based on that, with collecting data around the cases, the households, the supplies that they were given, and then post-intervention monitoring, we actually got very good data that could then feed into further modeling work, etc. So what my point is it is possible with modest figures of funding and high quality data to use the data beyond the initial firefighting. Thank you.
That's a great point, Aidan. And actually, I was about to ask you about what type of data collection do you conduct in Zimbabwe, UNICEF Zimbabwe. So it was nice to hear from you. As a follow-up question to you, what have you seen to be the implications of the current coronavirus pandemic for the wash sector in Zimbabwe? And perhaps how can we ensure that we continue to pursue the agendas of typhoid and cholera elimination control while still responding to the pandemic and also in the post-COVID landscape?
Yeah, thanks a lot. I mean, that's it's a big question, and of course the starting off risks really determine the response. So like George and Sophie had mentioned some of those in the response in their presentation, but of course we're tackling multiple hazards here in the country. It's there's economic, climate change impact in terms of rising temperatures, and also more intense weather events like the cyclone last year, and the drought that we're experiencing as well. So COVID is part of that high risk wash landscape, and what we can do for all of those risks is to start again with a solid understanding and evidence base to get or optimize the resources that we have for intervention. So what we have been supporting government of Zimbabwe on is a rural wash information management system, which tracks about 55,000 sources across the country on a real-time basis. And this is with enumerators at field level. And what we've seen with that is that the current ratio of water sources with water that are functional and protected is only about a third of the total sum of water sources. So what that means is that the risk from COVID for lack of access to the hand washing that George had mentioned, that shoots up straight away. So these very basic public health interventions are as valid for typhoid, cholera, and now COVID. And I think this has been maybe the only silver lining in the whole COVID pandemic, is that the importance of hand washing has really shot to the fore in the media and in the public. And now we're not only talking about when to wash our hands, but how we wash our hands as well, which is really an evolution in hand washing. Thank you.
Yeah, no, this is great. Thanks, Aidan. And actually, the World Bank presentation touched on how hand wash could be a factor in reducing SARS-CoV-2 transmission. So I'll open to input from all the panelists, but Steve, given your work in demonstrating the impact of hand wash and on disease reduction in low-income countries, can you give us any insights into quantifying the risk of transmission of COVID-19 with inadequate wash?
Yeah, it's at 12.4%. No. Quantification is difficult, but let's step back and consider some of these comments. We have known since Semmelweis demonstrated this 170 years ago that if we wash hands, we prevent disease transmission. So, and I really take Aidan's point of saying, wait, this isn't just about SARS-CoV-2. This is about cholera. This is about typhoid. This is about influenza. It's a good idea for us to wash hands and wash hands with soap. And so as we think about this, this gets to a core public health message. Do we have the infrastructure in place that makes it possible for people to wash hands with soap? So part of this, I do think, is we need to increase the priority. just as Ranjiv was saying, we need to increase the priority of saying, look, we need to have safe water in places, and you can't wash hands with soap and water if you don't have water there to begin with. I would say that one of the areas that is newest and is most exciting from my perspective is there is some new work coming out on mass media promotion and what you can accomplish with mass media promotion. The strongest evidence we have are these really intensive interpersonal communication. We send a community health worker, and we really encourage hand washing. But thinking about raising the attention to this and encouraging this, I think is something that the data increasingly support. And in this moment with the COVID-19 crisis, we can lean in on. And I think it's a little bit of a mistake when people say, yeah, but does that going to distract us from mask wearing, or shouldn't we do other things? 170 years of evidence, washing hands more prevents the transmission of person-to-person diseases, including COVID. I think we lean in and encourage and not worry so much about how much this is going to contribute compared to others. We have good evidence it's going to work. We're in implementation mode now. Let's work at what we need to do to increase these behaviors. And these are issues that WASH implementers actually have considerable experience with and working on. Thanks.
That's such a great point, Steve. Thank you. And Ranjiv, I'm afraid we're running out of time, but I have a question for you here as the director of the Acquire Institute. Which mission is improving health through clean water innovation? So given your work in this area, what do you think is needed to help accelerate change and WASH improvements, specifically as it relates to the control and prevention of infectious diseases?
Thank you, Denise. I'll try to answer that on 3 levels, at the institutional level, at the technical level, and at the sector-wide level. So beginning with the institutional level, I think an important innovation would be to consider incentives for better performance with respect to collecting and using data, and balancing the use of incentives with enforcement. Relying entirely on enforcement proves to be not so productive in many settings, and there are examples of how incentives have been used to improve water safety management that are quite encouraging. I would also, another innovation that I think is important to consider at the institutional level are tailorized or customized requirements for monitoring that focus on priority parameters. One-size-fits-all monitoring programs are difficult to achieve and sometimes can undermine the value of monitoring. Finally, at the institutional level, I think it would be, and this actually transcends beyond institution to sector level, is to think about the possibilities of pathogen monitoring in addition to fecal indicator monitoring. Fecal indicator monitoring, as most researchers know, is not giving us the best picture with respect to water quality. So that moves me to technical innovations then. Practical, affordable methods for direct pathogen testing that can be implemented in operational and surveillance monitoring programs. I think that would be a big step. And then building on the presentation from the World Bank, moving beyond explanatory factors for disease risk to models that forecast disease outbreaks. I think that would be a very important technical innovation that's also achievable. I think we're seeing some of that emerging with respect to cholera from Rita Caldwell's efforts and others. At the sector level, innovations that I think would promote the use of the collection and use of data include innovative financing for water safety management. There's a lot of discussion about financing for the overall delivery of water services, including smart subsidies. There's been a lot of interesting information coming from the World Bank regarding subsidies in the water sector. Strategies that apply these directly, financing and subsidies directly for data collection, I think will be an important innovation. I'll end on a note that Aquia has established a water quality assurance fund in collaboration with Ghana Water Company Limited in Ghana that supports, that mitigates their risk that they will lose money by increased water testing in rural communities. So I think there's a lot of good opportunity to explore in all of these areas.
This is great. Thanks. I am afraid we are out of time, but do any of the speakers and the panelists have a last word or anything else that you would like to say before we close the session?
Hi, this is George here. Sorry, I was in and out of the session because of some internet issues. So I just want to emphasize one point again that's kind of evident as from the presentations and the conversations that we had so far, which is the importance of data and how we should improve the preparedness of national institutions and national governments to any pandemic like say COVID, for example, which we're experiencing now, or anything that's coming, that's likely to happen in future, which require a lot of coordination not only on or at the institutional level on organizing a response, but also on prevention as well, prevention and even identification. For that, data is a primary requisite. And this is one thing that I would like to emphasize. And also, we should appreciate and we should start using the new tools and techniques that are coming up in the field of data, mining data and machine learning and a number of and big data methods, use of big data methods. These are all very useful and can be potentially used for a number of for these purposes, some of which we demonstrated in the presentation that we made today. I would end with this. Thank you.
Thanks, George. Any other final words? If not, we do have several more questions from the audience, but unfortunately we did run out of time. We are out of time. For the question that we did not get to today, we will be answering them in a post-event blog on our website. It is www.coalitionagainsttyphoid.org. Additionally, a recording of this session will be available next week on our session page, as well as at the Coalition's website. So I would like again to thank all the presenters and panelists for the informative presentation and discussions today. Thank you also to our audience today. We look forward to keeping this dialogue going, knowing that with greater collaboration, the public health and WASH sectors can collectively help to target WASH interventions for better disease control and prevention. Thank you very much.